A very good afternoon, everyone, and welcome to this session on addressing antimicrobial stewardship with the 2030 goals and real-world strategies. So we have three presentations. We have three experts speaking on the hospital pharmacy and the community pharmacy scenario and the convergence of the global strategies as far as AMS is concerned. And before I go to the actual session, I would like to tell you about some logistics. Being the first day of the Congress, I think this is still relevant and important. So here we go. We use the statements and declarations from the speakers and chairs to evaluate if there is any conflict of interest, and we have found no conflict of interest. Each speaker would be telling you about it. And the evaluation of the session, I request you not to forget to do the evaluation of the session. Please make sure that you evaluate this session via FIP Congress app. I am also sure that all of you, each one of you have downloaded the app from the Events app and the FIP Brisbane 2023. Download the app and enter the event code. I'm going to tell you the event code soon. You're welcome to ask any questions in the Q&A part of the program. So we will have panel discussion, question answer, ample of space for it after all the three presentations are over. And you might as well use the yes and no, the green and red pages in the Congress booklet to ask any questions. We kindly remind you not to do any recording, not to do any sort of recording when the session is on. And you may not download the speaker slides at the end of the session. Thereafter, subject to the approval of each speaker, slides will be available for all the registered delegates on October 1st on the email address which you have given at the time of registration for the Congress. So we will send you the link for all the slides. You're welcome to talk on the social media about the Congress, about the sessions, and the hashtag you can use is FIP Congress or FIP 2023. A very common but important request to all of you that please switch off the phones or please keep it on the silent mode. Let's not it be on the vibration mode, but on the silent mode, please. Thank you. Please take your belongings before you leave the room. I also have one more request appeal to you that the exhibition is opened yesterday after the opening ceremony, and there is FIP booth. And you can visit FIP booth and learn more about FIP's activity and its programs. FIP Congress attendees who are members of the following organizations may be able to receive the CPD points, continuing professional development points, following the attendance at the FIP Congress sessions from their respective organizations. So it is African Pharmaceutical Forum, Egyptian Foundation of Clinical Pharmacy, General Pharmaceutical Council of Spain, Lebanese Order of Pharmacists, Pharmaceutical Chamber of the Federation of Bosnia, Pharmaceutical Society of Australia, Pharmaceutical Society of Malawi, PharmaSwiss, Portuguese Pharmaceutical Society, and Society of Hospital Pharmacists of Australia. So after the session CPD code here is 8380. Please enter that code in your app in front of the session. And please, so after you record the CPD code, you may submit post-Congress the CPD claim with your respective organization utilizing the provided number, that is 8380 for today's session. Before we start with the presentations, let me all wish you a very, very happy World Pharmacist Day, and thank you for spending it with your FIP family here in Brisbane, the global family. Now we go to our session again, addressing antimicrobial stewardship with the 2030 goals and the real-world strategies. As I said, we have three presentations, and first presentation will be a convergence of global strategies for antimicrobial resistance. Second will be how can community pharmacists in low and high resource settings support antimicrobial stewardship, a real-world antimicrobial stewardship intervention example from Uruguay. And then we have how can hospital pharmacists in low and high resource settings support antimicrobial stewardship, a real-world antimicrobial stewardship intervention example from South Africa. Are we repeating the slides here for a change? Okay. We go to Dr. Laurel's presentation, please. Yeah. And the learning objective for today's session is basically to know about what are the resources available for AMS in different practice settings, and what are the strategies which are used to achieve the AMS in different practice settings and in different regions of the world. So it's my pleasure to welcome Dr. Professor Laurel Leggenza. She is PharmD, PhD, and she's the member of the FIP Hospital Pharmacy section, and she's the professor at University of Wisconsin, Madison, United States of America. So it's my pleasure, Dr. Laurel, it's all yours. Thank you.
Thank you. Thank you, Manjeri, for that introduction, and I'm thrilled to be here with you today. Thank you. So I am here in Australia for the first time. I see that many of my colleagues have traveled here, as well as many are from Australia today. And I have a special gift for you today, which is a postcard with information about a survey that we're doing, and I'll talk more about that in my presentation. So an outline of my presentation today, I will be presenting some background on antimicrobial resistance, and then talking about different frameworks that can be used to support practical examples of antimicrobial stewardship. And then we want to hear from you with our antimicrobial stewardship survey. So here's the problem. I think anyone who chose to attend this session today knows that antimicrobial resistance is a massive problem. It threatens the ability for us to treat infections in the future. And some background, we all know that initially we had antibiotics that were very effective, and then over time, more and more resistance emerged. There was a drought in development of new antimicrobials, and now we have some new antimicrobials in the pipeline, but we still need antimicrobial stewardship. So I would like to provide some background on some forces coming together for antimicrobial stewardship. And I'll start with going back in time and looking at the timeline of some of these frameworks. So even back in 2008, FIP made a statement on the control of antimicrobial resistance. And I'd like to acknowledge the FIP Basel statements, which were around the future of pharmacy, that actually are being revised here in Brisbane this week. Then, in 2015, we have the acceptance of the Sustainable Development Goals. And those are accepted as part of the 2030 Agenda for Sustainable Development. These 17 goals are distinct and yet interconnected around the health of humans, the environment, as well as animal health. So if we look closely to the health-specific goal, SDG 3, was around specific indicators to improve health. And then later in 2020, we started to see specific measures that were related to antimicrobial resistance, such as tracking multi-drug resistant infections, MRSA, and ESBL E. coli. But what's unique about these goals is that they can also be considered a One Health approach, that simultaneously we're looking at the interconnectivity of the health of humans, animals, and the environment. And in 2017, the revised FIP AMR statement recognizes the importance of One Health. I do some One Health research back in Wisconsin that I want to share with you today. Part of my research is looking at how is antimicrobial resistance potentially interrelated between humans and animals. Here are some photos from Wisconsin, as well as from Ecuador. In my recent research with colleagues, we collected E. coli samples, both from active infections and then also a colonization study. And we collected samples from humans, bovines, and canines to ask that question of, is antimicrobial resistance potentially being transferred between host species? And to do this, we looked closely at the genetics of the E. coli. And we were able to identify gene targets that were causing multi-drug resistance. And those are what those abbreviations are below. We also looked at something called septotype, which is a more quickly identifiable clonotype marker, so it's faster than doing a full sequencing. And these are our initial results. And what you can see is there's distinct patterns where some of the occurrences of groups or septotypes occur mostly by species, but in others, we do see some overlap. Especially if you look at septotype 361, you can see that there is some overlap in the gene targets as well as the septotype. And this research supports that it is possible that these E. coli are being transmitted, but further research is still needed. Also, from looking at this approach with the One Health approach, we looked at how can we better use data in practice to track potential differences in geographic variations in antimicrobial resistance. Any hospital pharmacist here today might recognize this table or an antibiogram. And what I see in my hospitals back home is that these tables are not usually used in active daily practice, but they contain some really important data. So what I did was I collected antibiograms from across my home state of Wisconsin in the United States. And we asked, if we look at this with a One Health environmental approach, how is antimicrobial resistance varying? And what we found is that there are differences in antimicrobial resistance, even across our state. We next asked, well, what about at a smaller granular level? And we then looked at this data by census block group, which is like a neighborhood size adjusted for population. And even looking at this at a neighborhood level, we see these differences. And what this means for pharmacy practice is that it's important that pharmacists recognize antimicrobial resistance varies by location, and that this data is important to have accessible to prescribe the most effective and appropriate antibiotic. So back to our timeline. In 2020, we have the FIP development goals. We also have the Sustainable Advancement for Pharmacy Worldwide roadmap. And I'm very excited about the work happening here in Brisbane on the version of the Basel statements. I believe the next version will include more specifics around antimicrobial stewardship. We also are seeing recognition on the interconnection of antimicrobial stewardship and sustainability of the environment, as well as the FIP development goals have their very own antimicrobial stewardship goal. And when I talk about antimicrobial stewardship, I'm referring to the coordinated interventions designed to improve and measure appropriate antimicrobial use. And within FIP Goal 17, there's specific goals, just like the SDGs, around workforce, practice, and science, even evaluating the impact of antimicrobial stewardship programs. And the guide is also available to look, and you can find this on FIP's website. Next, I want to hear from you. FIP and the University of Wisconsin is doing a survey around global antimicrobial stewardship practices. And I'm thrilled to announce today that we are launching the survey with this presentation. This QR code is available, as well as the link here, to take our survey. It is a research study, IRB approved at the University of Wisconsin, and supported by FIP with input from the hospital pharmacy section and the community pharmacy section. And my colleague has some postcards available, so you can take the link home with you and back to your practice site. Next, I'd like to share with you work that I'm doing with my colleague, Rainier Coetzee, who's here today and we'll be talking more later. So we've been working together on a project around Clostridium difficile infection as a partnership between the University of the Western Cape and the University of Wisconsin-Madison. And this project is based on an academic partnership as well as partnering with the local hospitals in the Western Cape. and it aligns with the antimicrobial resistance national strategy in South Africa. After we looked at what were the possible projects that our collaboration might look at, we found there was a gap in data around Clostridium difficile infection at the secondary level. So our research set out to develop a context-informed CDI intervention using that local data that did not yet exist and was not yet accessible. And then once we created this antimicrobial stewardship intervention, we looked at the implementation process with a dissemination and implementation science approach. Vernier is going to talk more about Cape Town in his presentation, but briefly, it's an urban area, and it has some of the greatest socioeconomic disparities in the world. So what we did is we recruited 4 hospitals to participate in our study, and we looked at data on patients tested for Clostridium difficile. And what we found in the district level, public hospitals, the majority of patients also had HIV, and many of them were immunocompromised. But what was most striking about our data is that we identified a novel risk factor for Clostridium difficile that was unique to this study. Patients testing positive for C. difficile were more likely to have tuberculosis as well. And this may be related to the extra antimicrobial use in this population. I participated in the data collection and went to the tea rooms at these hospitals where we did a manual folder review. And what was devastating about this project is that I went to the tea room and there was a stack of folders for my C. difficile patients, and 1 in 4 of them had died in hospital. We found that the odds of dying in hospital with a Clostridium difficile positive result was 4.7. And you can see here the outcomes from our survival curve. When we looked closely at how these patients were managed, we found the majority received metronidazole, which was consistent with the local guidelines. However, a large group did not have any treatment documented. And there was 3 reasons for this. Some patients actually got better and went home. Maybe they were just colonized with C. difficile. Some were lost to follow-up, and we don't really know what happened. And some of them died in hospital. And some of them died before the test result was even documented. So then we looked at the qualitative context, and I talked to providers, physicians, nurses, and hospital administrators to map how is the workflow for Clostridium difficile. And what we found was that there are significant knowledge gaps in C. diff, and this is an addressable aspect that with education can be addressed. We found delays in ordering the tests that could also be addressed. And there was plenty of resources available for good infection control. So with this context, we then developed our intervention, the diarrhea alert checklist, to quickly identify patients at risk of C. difficile, and then look to make sure they're getting tested, stop antibiotics that might be making the diarrhea worse, stop loperamide, which is contraindicated in C. difficile, and starting the appropriate treatment. And this was a sticker applied to the paper order form that was implemented with an implementation package of provider engagement and education. We invited the 4 hospitals from our baseline study to participate, and 3 of them accepted the intervention and implementation package. However, only one hospital displayed high uptake of our intervention. And we call this hospital 2 by sequence. And at this hospital, we did have measurable improvements in oral rehydration, contact precautions, and the discontinuation of loperamide. 1 patient died in hospital during the 3-month post-intervention that data was collected. So we talk about this entire intervention and analyzing it with a dissemination and implementation approach in our recent publication. And in this paper, you can find more details about the intervention, where we looked at, well, what was going on at Hospital 2 that helped support this intervention? And what we found is that the providers at this hospital were highly adaptable. They already had a learning climate, and key opinion leaders, key infectious disease doctors and physicians were highly supportive. And we need to get better as a profession in the other hospitals so that this project can continue to grow. So from the project, we have a ready-to-go designed intervention. We were awarded a hospital pharmacy section research grant to continue this project, as well as we're partnering with the Western Cape for the pharmacy-led Train the Trainer intervention program for Clostridium difficile infection in public hospitals. And I welcome any comments or feedback you have about this project, as well as our other antimicrobial stewardship work. So thank you. I think this is a great start to our discussion today, that addressing AMR requires a unified global effort, and we want to hear from you and what antimicrobial stewardship and antimicrobial resistance looks like in your country. So we invite you to take our survey, as well as share this survey with your colleagues back home. Thank you all very much.
Thank you, Professor Laurel, for this wonderful presentation. She not only focused on the WHO, UN, and FIP policies and guidance documents and other resources, but she has also given a wonderful example of the CDI project from South Africa, and we'll be hearing more about the project from our other colleague as the third presentation. Right now, it's my pleasure to call upon our next speaker, and she is Leticia Caligaris from Uruguay. She's community pharmacist, and she is newly elected EXCO member of FIP's community pharmacy section. She's going to talk about how can community pharmacists and low and high resource settings support antimicrobial stewardship, a real-world antimicrobial stewardship intervention example from Uruguay. I welcome Leticia.
Hello. Okay. Hello, my name is Leticia, and I am from Uruguay. I do not have conflict of interest, and I'm going to tell you that Uruguay is a country in Latin America. We are only 3.5 million people, and we have less than 1,000 community pharmacies in Uruguay. In Uruguay, we have laboratory surveillance as well as surveillance of healthcare-associated infection, but we do not have a national system for antimicrobial consumption surveillance, which is made very necessary now. So we are working in design one that can implement now the using a reliable and representative data source for the actual antimicrobial consumption. We need to have indicators, also the quality and the quantitative indicator. We need to know about the age and the type of infection that the consumption of the antimicrobial. So, in 2021, we ran a survey that we call the knowledge, attitudes, and the practice of regarding the use and acquisition of antibiotics in the population in Uruguay. But first, we have done these stages. We have arrived at this service was after completing the following stages: the generation of knowledge and evidence of MIR, and when we have the awareness stage for both consumer and healthcare professionals. Then we came to the stage associated with the prevention of healthcare-associated infection. At this point, program and hospital were strengthened. The antimicrobial consumption stage is where this survey is framed. Initially, it's intended to be conducted by person in community pharmacies, but we have the COVID-19 pandemic, so we have to move the surveillance, the service, for in-person to telephone interview. This simple change changed everything for us. We have to speak with communicators. We have to review our questions because it's not the same talking in person but talking by telephone. As a result, we have to engage services of communicator and company experience in the field of telephone service. For this reason, the survey was initially redesigned. So we have to run first a pilot plan, and then we have to move to a new question and new ways to practice the questions. And this is what we have done. This is the name of the study. We have this study we call 800 persons by telephone, and the duration of the interview was 7 minutes approximately. And this is what the population that answered the question. The 40% lives in Montevideo, which is the capital city, and the 60% live in other parts of the country. I'm going to talk about the age. The 27% of the consumer of antibiotic was under 18 years. In this case, responsible adults answered the question. Between 18 and 59 years, there was, 44%, and 19% was more than 16 years. This is when we ask about the multiple use of antibiotic. Of course, the respiratory tract is more than 40%, and we have the throat treatment, lungs, ears, flu, and sinusitis. The urinary tract infection was next, and we have teeth with all related with mouth, and with a dentist is the prescription. When we ask about what antibiotic we use, we have here a stage, but all and the more used was amoxicillin, which is okay with our guys with infection in the respiratory tract. And we can find also that in children and less than 18 years, there's no use on ciprofloxacin, which is okay with alignate with the same guias. And but we have a high percentage of persons that don't remember what kind of antibiotic they take. When we ask about who recommended, the medical doctor or the dentist was the 19%. And that also we have that he or she decide that he have to use 7%. A friend told that you must consume an antibiotic, and 1% maybe in the pharmacy they say that they have to take. When we ask about where she or he get the antibiotic, we have the 60% of obtaining hospital pharmacies, and the 24% in community pharmacies. In community pharmacy, we have two kinds. 52% come with a prescription, and 48% no have a receipt for the community pharmacy. That could be because of sometimes the dentists in our country told the people to take some antibiotic orally, and they came to the pharmacy with the dentist on the phone, and they say, yes, he have to take some antibiotic. Then we asked about if the person knows about that buying antibiotic without prescription is legal. And near the 50% know that it is illegal, but we have some number that we don't understand much. We have that the 25% of the university, person with university student think that it is illegal. The 20% of healthcare personnel think also that it is illegal. So we have to educate more our healthcare practitioners. And on the other question, we have what happens if a person takes an antibiotic without indication, and the 30% indicates that they don't know what could happen, and the 20% indicates that it can be a bacterial resistant, and 3% indicates nothing. So also demonstrate that we have to improve our communication to our patients. We also ask about if they know any place to safe disposal of the antibiotic, and most of the people say that they don't know, sorry. But we have a plan called Pleasant since 2007, and it have this kind of boxes in community pharmacies and community hospital pharmacies too. And sometimes we think that people don't see very well, and maybe we're thinking it's changing the colors or doing something more educating. Well, this is what the Ministry of Health and WHO conclude about this. And they say that the antibiotic usage pattern in Uruguay between 2019 and 2021 reveals that respiratory infections are the most common reason. No significant issue was identified regarding the prescription. And we have to emphasize that prescription are required and they are not over the counter. So we run a working plan, and the working plan starts with a steering commitment with the Ministry of Health, the Ministry of Ambient, and the Ministry of Vet, and governments of Montevideo. Then we create 4 instances to work to elaborate the guides, and the first meeting was on the 1st of September of this year. And the second meeting was on the 8th of September this year, and we decided to have some implement and material to have in our community pharmacies. And we are going to present officially this plan on the 24th of November in 2 months. And this is where our plan name is Promote and Support Action for the Development of a Comprehensive National Antimicrobial Resistance Plan within the framework of the project Working Together to Combat Antimicrobial Resistance, and it supports by Union Europea, the WHO, and the FIO, and the Animal Organization to the Sanity. This is going to be our logo. It's a pill with a kind of fighting. And this is I take this from the UK, and we are going to have our same material is antibiotic checklist. One is this in yellow is used for the patients, and this is going to use like checkpoint list for the worker in the community pharmacies. And of course, maybe next year we will have our more numbers to show you, and we'll be happy to be here. Okay, and thank you, and have a pharmacy week. Okay.
Thank you, Leticia. That was a wonderful presentation, and congratulations on your project of the consumer survey in Uruguay. Also, congratulations for coming up with the new working plan on antibiotics, and I'm aware you're part of the committee. So all the best for your work. I think there are a lot of issues around antimicrobials around the world, and there are differences as well as similarities. And I can relate to the examples in Uruguay where many people think that it is okay to take antibiotics without prescription. And so we have seen it in many parts of the world, and the pharmacist has a huge role to play to improve this situation. We go to the next presentation. How can pharmacists in low and high resource setting support AMS, a real-world AMS intervention example from South Africa. And for this presentation, I call upon Professor Renier Kotze, and he's the professor at University of Western Cape, School of Public Health in South Africa, and he will be presenting the project which is done in South Africa. Welcome, Professor Renier.
So thank you to FIP for inviting me to present here today, and thank you for those who are attending. I hope that you will find the presentation interesting. So there are no conflicts of interest to declare, although there was a grant support from the International Society of Infectious Diseases and the Pfizer Global Medical Grant. So making sure patients get the right medicine at the right time is critical to preserve antibiotics in primary care. And it is true that there is unlikely to be a silver bullet to prevent antimicrobial resistance. And we most probably need a multidisciplinary approach if we want to do that. And South Africa has shown a lot of progress in terms of implementing policy to fight antimicrobial resistance. But there is a lot that needs to be done which cannot be answered by research. And some of this includes limited access to technology. Our records are still paper-based. Our health facilities are under-resourced. We have a very big migrating and mobile population, and there's a high infectious disease burden in South Africa. Not even to talk about the problems that our government needs to address. For example, unemployment, housing, education, water and sanitation. For those of you who have been lucky to visit Cape Town will agree that it is a beautiful city as soon as you get out of the plane. And I hope that you will visit us next year in 2024 when we host FIP Congress in Cape Town. Yes, you can clap to that. But just as you leave the airport, you are faced with a multitude of townships, informal settlements, where just over 4 million people live in poverty. Life is pretty hard for these people without proper sanitation, no water, no electricity. You are confronted by the townships of Khayelitsha, Delft, Mitchell's Plain, and so many more. And it is these people that need our help the most. In the Cape Metro, we have just over 100 small clinics, 8 district hospitals, and patients can access these health care facilities for free. However, just as in Uruguay, an antibiotic needs a prescription and cannot just be handed out. If we want to improve prescribing, it is essential that we understand the context in which doctors, nurses, and pharmacists work, where they have to manage very difficult but easy to treat common infections. So way back in 2018, with my colleague Oliver van Hekke from Oxford University, we started exploratory work with local clinicians, pharmacists, and nurses to see how can we come together to address the issue of AMR in primary health care. And I will briefly give you an overview of what we have done over the past few years. The first study that we conducted was the Petri study, and the aim of the study was really to explore the perceptions of primary care clinicians at these publicly funded primary care clinics about the potential of using point-of-care devices in urinary tract infections and acute cough. And so we learned amongst the many barriers to just healthcare, there were important social determinants of health that override guideline-driven antibiotic prescribing. And more importantly, there was no prospective data on antibiotic prescribing linked to clinical indication. There is a saying in Africa, if you want to go fast, go alone. If you want to go far, go together. And this is exactly what we did. The second bit of work that we did was to bring pharmacists, bring doctors, bring nurses together in one room and understand their basic needs. How can we address the issue of AMR in primary health care and make them work together? And this is where the PRINCE study was born. The aim of the PRINCE study was to assess the implementation of a pharmacist-prescriber partnership to track and optimize antibiotic prescribing for patients presenting with an acute cough to these public-funded primary healthcare clinics in the Cape Metro. And on the screen, you can see a multitude of our co-collaborators. The objectives was to collect baseline observational data of patients presenting with an acute cough. We wanted to assess the proportion of antibiotics prescribed for acute cough that are concordant with the local guidelines for primary health care, and then to measure the impact of this PPP on health outcomes 7 days post the visit of the patient. And just interesting to note that in the Uruguay study, how many patients presented also with a sore throat, which you can probably also describe as a cough to healthcare facilities. The PRINCE study is a pharmacist-driven, prospective observational study with audit and feedback strategy. So we chose clinics where there was a pharmacist present that can do the dispensing. And our primary outcome was to assess the proportion of prescribed antibiotics for an acute cough and whether this was in agreement with the National Standard Treatment Guidelines for primary health care. So how would something like this work? As expected, we had a multidisciplinary approach to AMS that we followed, and we divided the task between a prescriber, which could be a nurse or a doctor, the pharmacist, and then also the research team. The doctor would see the patient, they would complete a short set of questions, only 8 questions, and then send the patient to the pharmacy. At the pharmacy, the pharmacist would review the prescription for correctness and whether it is in line with the National Standard Treatment Guidelines. They would then notify the clinicians via social media WhatsApp, using the patient ID to indicate whether they were prescribing in accordance with the Standard Treatment Guidelines. If they were not, they would then indicate to them how they can improve the prescribing and correct the prescription. The research team will then follow up with the patient within 7 days after receiving the visit to the health facility, whether there was improvement in their symptoms, that they need to go back to the healthcare facility because they did not feel well, or were they even admitted to a hospital. What did we find? We conducted the study in 5 clinics, and the interim results showed in 405 patients that, as expected, most of our patients were from the Black African race, mixed race, and there was an even split between adults and children. 8 out of every 10 patients received an antibiotic for acute cough across all 5 facilities. Community-acquired pneumonia was by far the top clinical indication for giving an antibiotic. You will note that amoxicillin, coamoxiclav, and Pen-V was the top antibiotics prescribed, which was also the case in Uruguay, I saw. These antibiotics are also part of the access antibiotics as classified in the AWARE system by WHO. And if you want to know more about the AWARE system, Dr. Huttner will give a presentation on the AWARE system during the plenary session that will happen after this session. the proportion of antibiotics prescribed for acute cough for each site were similar. It ranged between 69 to 100%, indicating the problem was not necessarily facility-specific, but was a general trend. So what were the conditions that antibiotics were prescribed for? As previously said, the top clinical conditions were community-acquired pneumonia. 4 out of 10 patients were prescribed an antibiotic for so-called community-acquired pneumonia. In the UK, that is just 5 to 12%. Almost 60% of antibiotics were directly dispensed by nurses who did not send their prescriptions to a pharmacist for intervention, purely because of laws, rules, and regulations in South Africa. There was a significant variation between the sites for clinically diagnosed community-acquired pneumonia, as you can see. However, there was no difference, no statistical difference, between nurse prescribers and doctors when it came to community-acquired pneumonia. So what was the relationship between the feedback that pharmacists gave and guideline concordance? And that you can see on the green and the black dotted line. Pharmacists were able to make appropriate recommendations. There was a very high percentage agreement of prescribed antibiotics that were in agreement with the local guidelines for dose, duration, and frequency. But for our secondary outcome, there were limited data available for firm conclusions on the clinical outcomes for these patients. So what were some of the strengths? According to us, this is one of the first studies in the region to generate prospective data to describe what happens in patients with an acute cough. It was a multidisciplinary QI project involving the whole primary healthcare team, and this is a light touch intervention that is scalable. But there were limitations. How do we as pharmacists incorporate feedback to nurses when we do not see their prescriptions? The follow-up data was weak, and we do question the proportion of true radiologically confirmed community-acquired pneumonia in this setting. So in summary, this study is collecting important prospective prescribing data for acute cough, and it is critical to accurately assess what problems there are in terms of access to and excess of antibiotics in socio-economically disadvantaged communities in South Africa. The study will characterize the patient population, and it will give an indication of the proportion of antibiotics that are guideline concordant. And this is critical for benchmarking if we want evidence-based initiatives around antimicrobial stewardship. As always, there's future questions to be answered and more research to be done. And so we will embark on research around the clinical and the cost-effectiveness of point-of-care testing for patients who come in with an acute cough. And I hope to report back on the findings in Cape Town in 2024. Thank you.
Thank you so much, Professor Rainier Kotze, for the wonderful presentation and the project, the work which they have done, the pharmacist-driven project, both of that, the PET, TRI, Petri, and the PRINCE. They're so interesting, and I can understand that this is one of the first kind in the region. And thank you for being very open and bringing all the facts to the table. And we can see that the nurses have been dispensing antibiotics, And we can see, as I said, there are so many similarities and differences. The loose regulations, or the regulations are good, but then the weak enforcement of the regulations is very common in many parts of the country. So now, after these three very interesting and insightful presentations, the session is now open for question and answer. I have plenty of questions for my panelists, but if there are any questions from the audience, I encourage you to stand up, and not stand up, but just say your name, and our volunteer would be with you with the microphone, and just say your name and from where you come, and have a question. We have question right here from Sabiha. So, yeah.
Good afternoon. My name is Sabiha Isaac, and I'm from South Africa. Thank you very much for three very interesting presentations. With your permission, Chair, I have a question for each one of the panelists. So, Laura, for you, very interesting One Health study. I'm working in One Health as well, and we have also shown similarity of bacterial strains and resistance genes within humans, animals, and environment, but we struggle with showing the directionality and the transmission dynamics. So I'm wondering whether you have any thoughts on that. And just as a comment, FIP has updated its policy statement, and it was approved at the board or by council
in the council
2 days
meeting
ago.
on,
Yeah, 2 days ago.
Sunday.
So one more to add onto your slide. Letitia, excellent work. I think that your work is going to inform your national action plan. Did I get that correctly?
Yes.
Okay, so make sure that the pharmacist is leading somewhere along the line and doing that kind of work. My question to you was, do you have, how prominent is substandard and falsified drugs in Uruguay? Are antibiotics counterfeit? Is that a problem or not? And then, Renia, maybe I shouldn't ask you a question because I'm from South Africa and we know the type of work, so excellent work. Point of care testing, I'm just wondering how affordable it will be within our healthcare system and how important that economic impact analysis and policy impact analysis is going to be. Thank you.
Thank you, Sabiha. Thank you.
Thank you, Professor Isak, for those wonderful questions. And yes, we're thrilled that the new sustainable policy is now approved. To answer your question, it is a quick answer of no. I do not have data to prove the direction of transmission, but this is a very interesting question because knowing the answer could help inform policy to help prevent further transmission. I can tell you a little bit more about the study that I didn't include in my presentation, that we also collected the addresses. As you saw, I'm very passionate about mapping. So I have the addresses of the humans included in the study. We were not able to get the animals' address, but we got their veterinarian's address. So we assume their veterinarian is in the area of this animal. Farm data is also a little complicated because the farm could have a headquarters very far away from where those bovines live. So we looked at it and we mapped it, and we hope to submit our paper with the results soon. But what we found was that because the way the data was collected, it doesn't have a perfect overlap. So again, we can't prove anything, but what we do see is that in some counties, there is high resistance in all three species, and we see these septotypes, which are a quick result as a proxy for full sequence. So there's some similarities that support possible transmission, but again, we don't know yet, and hopefully soon we can get these results to help support further policy. Thank you. And I believe Leticia would like you to repeat your question for her.
Sorry, I asked about substandard and falsified antibiotics. Whether it was a problem in Uruguay.
Yeah, so that's for Leticia. Regarding the falsified and substandard antimicrobials, is that a problem in Uruguay? That's right, correct? Yeah. Do you have it as a big problem as far as antimicrobials are concerned? Professor Sabiha, am I correct? Yeah. Do you have the spurious, say, or falsified and substandard antimicrobials? Is it a big problem?
No, we don't have that problem because all the antibiotic passed several studies, and the Ministry of Health reviewed all the studies. And yes, I am working to put our profes in front of the One Health from Uruguay. Yes, thank you.
Yeah, thanks, Leticia. And I just want to remind everyone and that in the next plenary session, no, we are not, yeah, we'll be here. So at the plenary session at 4:30, we'll be talking about, the WHO expert would be talking about the falsified and substandard medicines, antimicrobials especially. So I go back to Professor Inia. Yeah.
Can you? Yes, thank you, Prof. Sabia. I knew that question's going to come. So point-of-care testing is rather expensive, and that's why we want to do a cost-effectiveness and a clinical study in one go in order to determine whether it will really benefit the patient, but also the country's pockets. We have seen that so many patients receive an antibiotic for so-called community-acquired pneumonia, and yet in our focus group discussion with the prescribers, they were not convinced that there are truly that high number of community-acquired pneumonia in South Africa at primary healthcare level. And if we also compare our data to other countries, we noted that it's far higher than the UK, where it's 5 to 12%. So we do take note of that.
Thank you. And there is a FIP resource on point-of-care testing and a pharmacist. So you may like to go to the FIP website and have a look at the report. Yes. So next question here. Yeah.
Hi, I'm Shajol. I'm a postdoc fellow from Deakin University. So my questions is around the CDI, about that one. So did you have chance to know the percentage of MRSA with that sample collected, and also like in low and middle income country, access to the antibiotics is really a problem. So in terms of availability of vancomycin or meropenem or other things, and how did that impact to the management of that cohort of patient? And I have another questions to regards to the point of care CRP testing. So what was actually the role of pharmacist, actually, whether the pharmacist did the test as part of the trial, and how receptive and acceptability among the prescriber, allowing pharmacists of doing that. And just to make a comment with regards to Sabia's point about cost effectiveness of point of care CRP testing. So we recently conducted a scoping review to understand how much evidence out there. Actually, it is very limited. And there is no more study on the cost effectiveness, only 2 trials in UK that propose the cost effectiveness thing. But the thing is, like, if we can use like as a national scale and a large scale, then actually it indicates that it could be cost effective, but still we need a lot of evidence. Like, we actually got only 20 feasibility study around the world. That includes the only 5 studies on point of care CRP testing, and the other 15 studies is about point of care, the rapid antigen testing for gastroenteritis. So still, there's no randomized control trial in the primary care context. So we need to explore those effectiveness and cost effectiveness in future. Thank you.
Thank you for your questions. Can you go back to your first question to clarify? You're asking about MRSA in the C. diff population, and what was the second question?
Yes, and how does the access and availability
yes,
of
I remember
antibiotics
now. Thank
problem
you.
actually influence?
Yes. So in our C. diff study, we did not collect data on MRSA. We did look at how many antibiotics the patients had in hospital, but we couldn't really see what they were taking at home before being admitted due to the limitations of the paper record. So I don't know what the rates of MRSA are, but many of our South Africa colleagues in the room might be able to report on that. And then access to antibiotics, I would defer to our South Africa colleagues on those as well.
So one of the big problems in low to middle income countries is the actual access to the access drugs on the AWARE classification system. And so one of our South African colleagues, Professor Mark Mendelson, says, we don't need new drugs. We don't need anything new in the pipeline for Africa.
Yes.
We need access to the access drugs to address the problems that we face. And so in South Africa, we are very lucky to have access to vancomycin and the other antibiotics. We do not have access freely to fidaxomicin in the public sector. It's only in the private sector due to the cost. But we do think that we are able to treat vancomycin effectively with, or we treat C. diff with vancomycin effectively.
And I would like to also add that as a result of the C. diff results presented today, the guidelines in South Africa now include vancomycin as a first-line option. When we started this study, metronidazole was the only first-line option for all patients.
Yes, thank you. And I think there was a question on point-of-care testing, right?
Pharmacist role.
Pharmacist role, where the pharmacist did that, and
So as I've indicated, the PRINCE study was only recently completed, so we don't have an acronym for the new study because we will only start with the process in 2024. So we haven't rolled out the study yet, and we are still working to understand, due to the context and the logistics of how things work in these primary healthcare clinics, where the pharmacists will fit in. But we hope that if we can initially have prescribers and patients see that the point-of-care test is negative, there won't be that urge to prescribe because I'm afraid I'm sending this patient home over the weekend with no antibiotics. We've also heard that many patients just want an antibiotic, so they go to a clinic to ask for antibiotics. That is what came out of our also knowledge, attitudes, and perception studies, where patients actually ask for antibiotics. So we almost want to see if we can use it as a behavior change to give doctors the confidence in prescribing an antibiotic or deferring. But that study hasn't been conducted yet.
yeah, well said. I think, as you said, the access to antibiotics is important, but I would also say that the awareness about AWARE is also very important, which is lacking among many healthcare professionals around the globe. And so that is also one of the challenge. And when you try to sensitize them about it, it's like we are entering into their area, their territory, and we are trying to impose something. So it is a challenge in many parts of the world to make them aware and to bring the behavior change among the prescribers. Yes, so next question.
Hello, my name is Syed Raza, and I'm a Director of Pharmacy Services at Aga Khan University Hospital, Karachi, Pakistan. I think, one of the things, Manjeet, is the access to the training and development. It's not a question, and it's a suggestion come question, that there are very less or low opportunities for the training related to the antimicrobial stewardship program, certification, things like that. Since last 2-3 years, in our hospital, the usage of broad-spectrum antibiotics reduced greatly. But what we did, basically, we borrow some of the guidelines from American Society and some of, the Joint Commission International accreditations. But there are no formal training as far as, low and middle-income countries. If with this forum, we can make an effort so that we can train the workforce of the pharmacists in order to make a contribution in terms of the greatly significant role play for the control of antimicrobial stewardship program is important, because there's a war between a physician and a microbiologist when we were interventions and doing some of the prospective audit sharing with them. They thought that they got training from outside and they have certification. I think some accredited certification required for pharmacists in order to control, further improve the usage and utilization of antimicrobial stewardship program. Thank you.
Yeah, good suggestion. And I think the AMS, what he means is AMS training. And then we at AMR Commission, my colleagues are here, so Professor Sabiha, Luna, and I think maybe some more. I can just see two of them. So we'll definitely take this up, and we have been thinking about it. So what he said is the pharmacists should be more empowered so that they can convince about the AMS strategies. Thank you.
So can I comment on that?
Yes, please, go ahead.
So in South Africa, what we have done a number of years ago was to actually bring all pharmacy schools into one room and talk about antimicrobial resistance and antibiotic stewardship programs and how do we actually train our students. And that resulted then in, we were very lucky to have a student that took on the task. And so ultimately we did a desktop review. We interviewed a large number of specialists in the field of AMS and AMR and asked them what's the role of a pharmacist. And we were then able to publish a recommended curriculum on AMS and AMR specifically for pharmacists in low to middle income countries. We took it further and we then approached the South African Pharmacy Council to ensure that when pharmacy schools go for what we will call accreditation or they get reviewed by the council, that is one of the outcomes that they need to pass. So they actually ask the pharmacy schools, what and how do you teach antibiotic and stewardship and antimicrobial resistance? I am very fortunate. We don't have many dental schools in the country, but I am now working on a project where we are going that same route to help the dental schools developing a curriculum on AMS and AMR for dentists, which will then go to their council for approval as well. So I think from an education point,
Yes.
it is important that pharmacy schools make an effort with that. Now, Prof. Sabia Esak will also confirm that we have debated in South Africa a lot whether we should have an antibiotic prescribing passport. So develop a training material, you get certified, now you can prescribe antibiotics. So it's maybe said with tongue in the cheek, but that is how we are starting to think about it. What training do we give prescribers and dispensers to make sure that they are aware of AMS and AMR principles?
Great. This is a great example. And I was coming to this regarding the question to all the panelists, but I see more of questions from the audience. Yes, please. Yeah.
Hi, I'm Shukri from University of Sydney, a postdoc and working on AMS program in Vietnam and Sri Lanka. It's really interesting presentation and very well done. I have some sort of, want to make some clarity about your presentation. The number one is, my understanding in developing countries, especially like low and middle income countries, the pharmacist's capability or qualification varies from pharmacy trainees to degree holders, and in between there are so many different qualifications of pharmacists. So particularly in your country, especially Eureka, what sort of pharmacy qualifications you have there? And then I understand you did a telephone survey on pharmacist perception and so on. So how best you can validate these self-reported findings in terms of actual practice? Because in other countries, we have seen some, big variations between actual practice and self-reported practice or whatever perceptions of pharmacies. And I have one small clarification again from Professor Rinia from South Africa. Actually, yeah, acute cough is a problem, but I want to understand how all these cases of acute cough were like bacterial infections, or how you validated that to prescribe 82% of these cases to antibiotics. So, and what was your definition of acute cough in your study, something like that? Thank you so much.
Thank you. So who takes it first? Leticia? Yeah.
Well, in Uruguay, we studied for 5 years, and we don't have reaccredited our member. So we only study 5 years, and then we have to go to the Association of Pharmacists, and where we have trained. But we don't have to prove our, we don't have accreditations. The last, can you tell me the second question, please?
Yeah, I was wondering how did you validate the self-reported findings with actual practice? Because in some other studies we found in developing countries, the actual practice is much different than the self-reported practice.
Yes, well, that's a big question. In community pharmacy in Uruguay, we have some recipes that keep in the cloud, so we can go to the cloud and clarify what we're seeing. And the other way is that we have not much community pharmacies in Uruguay, and we are a very small country, and we know each other, and sometimes we can check with our colleagues. That is the real reason.
Yeah, so thank you for your questions, also difficult questions to answer. So just in terms of the acute cough, so what we did was a patient would come into the health facility, they would go be seen by a doctor or a nurse prescriber, and if they reported any symptoms, and it included a cough, the prescriber hopefully would think about the PRINCE study and then recruit the patient. So we probably missed quite a lot of patients that came in with an acute cough, especially after hours. And an acute cough excluded anything that might have been investigated for TB. So we did not include TB patients in the study. And so an acute cough was just anyone that present with a cough for less, for within a month. Because why we chose a long period was because often our patients would cough on end before they make a decision to actually then go to a healthcare facility. So we kept it very broad. And the reason for that is often, it could be anything. It could be viral, it could just be bronchiolitis. So we did not confirm that it was a bacterial diagnosis. So these were clinical diagnoses made by prescribers. We do not have the luxury of doing blood cultures or any other testing, not even x-rays, often in our settings. So it was only on how the prescriber seen this patient as clinically ill with a cough and they needed an antibiotic. So we didn't confirm it. And that's why we now need to move to the next phases to understand how do they actually make these diagnoses, because in our focus groups, they actually questioned themselves.
Okay, yeah. Good luck with the next part of your project. Any more questions? Yeah, please.
Hi, my name's Sam. The introduction of AMS strategies relies on the adoption of change in healthcare professionals' practice. Is there any resistance from prescribers, especially in studies that essentially have a pharmacist correcting doctors' prescribings, like in PRINS?
I didn't hear that question. Can you just repeat the
so
question?
I had this question for you too. I mean, he has already asked. So whether there was, how did prescribers receive the, how are they receptive, or is there any resistance, or do they feel like insulted? So how do they take it when the message goes, or when it is told that this is not as per the local guidelines? Yeah.
So you will recall that we also did a workshop prior to starting the PRINS study, where we got prescribers and pharmacists into a room, explaining to them how we see AMS happen in primary healthcare, presented on examples in other low to middle income countries. And we asked them whether they thought there is a problem in terms of AMS happening at a local healthcare facility. They then themselves came up with a solution of saying we need an integrated approach where pharmacists, nurses, doctors all work together to address the AMR question. It's then that we moved on to the PRINS study after they have explained a process that they were willing to follow. So they were happy to have what we call a WhatsApp group where they can be connected to the pharmacist, get real-time feedback from the pharmacist. It also helped the pharmacist not to need to go out of the pharmacy, track down the doctor where they are, have a discussion with them and come back. Yes, they would also from time to time have interactions if the message was not cleared. So the WhatsApp was a means of connecting them, and we did not really find any resistance. No one declined being on the WhatsApp group.
That's excellent. So I think the groundwork was done very well, and so they were aware that they would be receiving such messages, and what's the reason for it. So that's excellent example. Any more questions in the audience? Yes.
Hello, my name is Mignon Avent, and I'm from Brisbane, Australia. So my question is a lead on the WhatsApp group. And I just wanted to ask, did you notice an improvement in appropriate prescribing of antimicrobials as time went on for the use of the WhatsApp group?
So it's about the WhatsApp.
Can you please repeat it? It's about the WhatsApp group that we know, but then, yeah.
Sorry, there's a bit of echo with this microphone.
Slight,
but my question is relating to the WhatsApp group, and if you noticed an improvement in antimicrobial prescribing as time went on utilizing this method.
So initially we did not think that it will bring a change, but there wasn't a remarkable change initially. I think if we were able to continue for a longer period, we would have seen something perhaps, but I think the time frame that we followed the process was maybe a bit too short. Like I said, we had focus group discussions, and so the pharmacists themselves noted when the prescribers were more engaging on the WhatsApp, they felt that those prescribers were the ones where they could see anecdotally an improvement in their prescribing. But it wasn't really something that we looked at specifically. But it could very well serve as another form of an intervention.
Yes. There is one question here, and one more there.
So in terms of the WhatsApp application, actually, I worked in the Timor-Leste National Hospital, and using WhatsApp is a great platform to bringing the microbiologist input, the pharmacist input, and directly pharmacist going to the ward, and whatever happens with the patient, that all message is ongoing, and they're asking questions in the difficult situations to the real expert, like who are working on site. They are providing some suggestions. on the on-site and real actions on time. So, but how does that work in the primary care settings? Like in inpatient settings, like the patient already admitted and you go for actions. But in primary care settings, how did that work? Like if pharmacists assess the guideline adherence of the prescriptions and send message in the WhatsApp, when GP actually undertook that actions and when it happens, like how practically worked?
So I don't know how familiar you are with the primary healthcare setting in South Africa. So this was
Not really.
this was in publicly funded facilities, which means there is one facility with a pharmacy and then the consultation rooms connected to it. So once the doctor saw the patient, they would go and queue for the prescription. Once the prescription goes to a pharmacist, they identify it as a Prince study patient, and they needed to intervene, they would then immediately send that WhatsApp. So the prescriber was not off location. They were in the location where it actually happened. So it then required the pharmacy to either return the prescription and get it corrected and signed again. But this process was also followed in such a way that it didn't cause any further delays for the patient. So we cannot expect a patient to go back and wait in the queue at the back. So that's why we wanted real-time feedback to the prescribers so that they can act upon it immediately. So we felt it worked in our primary healthcare setting. If we go to the private sector setting, it's completely different. There's no doctors necessarily where the pharmacy is. The patient has probably driven a few kilometers to get to a pharmacy. So we might need a different type of intervention that can happen very quickly in that situation. But I think in many countries, it is a challenge when you've got privately owned pharmacies and doctors sitting at consultation rooms far. You need to phone them. You can talk to them, but how do you legally then make the necessary changes always on the prescriptions without sending patients backwards and forwards?
Yes.
But some rules in South Africa are changing, where we do now accept electronic prescriptions, which will help.
True, yeah. Yes, there are two questions on the other side.
Thank you very much for your presentation. My name is Okamaka Okafo from Nigeria. It's a general comment on what the three of you have well presented. Because we have, you've spoken about the curriculum of the pharmacy training the pharmacists and the doctors for them to know much about antimicrobial stewardship. In many developing countries, the issue is not the curriculum content. It's not that the pharmacists don't know what to do or that the doctor does not know what to do. The major problem we have in developing countries is the lack of prescription policy for the doctor to know that he only prescribes and the pharmacist dispenses. So in situations where you go to school and you have been trained on antibiotic microbial stewardship and you come into the community setting and you don't get prescriptions from morning till night to dispense, and patients come to your pharmacy and say and demand antibiotics, and you keep the antibiotics and nobody asks you of them because the doctor is prescribing and also dispensing. So that is the major issue we have in the developing countries. And there is also unguarded access to antibiotics. So when you talk about antimicrobial resistance, you know what drives it is the poor antimicrobial stewardship. So people have very easy access to antibiotics. So the AMR is a cycle, it continues. And we migrate from one country to the other. So even when you solve the problem in developing countries, the fact that there are people sick in developed countries, people come from other places or to give you that issue of antimicrobial resistance. So we have a lot of problems to solve fundamentally in this regard. And I'm happy that WHO is going to present maybe by 4:30. So because we need to actually find out how we can have an effective and practicable activities or interventions that will make us to adopt the antimicrobial stewardship,
Yes,
especially in developing countries. Thank you.
I agree with you.
Yeah, there's no silver bullet.
There is no, there's no one common solution. There is no one-size-fits-all solution. And that's why we continue with our AMR discussion even later, and we have a plenary coming up at 4:30, and I'm welcome you back for that plenary. But then before we close today, we can take last question. Farah, is it okay? Just one more question, and then we would like to close, yeah. We just have 2 minutes remaining now.
My name is Samuel Donko, Ghana. I believe where we are getting to when we talk about antibiotic stewardship or antimicrobial stewardship, we need to really take action. And we've all talked about access to the medicines, especially in our developing part of the world. We need to really look at it. Is it time that certain antibiotics are classified as controlled substances, just to protect them for the future? We do them for psychotropics, where these medicines are controlled. The importer brings the product in, they distribute it, they have to submit records to the regulatory authorities, and you follow them readily to know that these medicines, where did they go? Who did they prescribe to? So if we agree that products like amoxicillin and others, we can leave them, but start protecting maybe some other antibiotics for the future, and ensure that these ones can only be used by certified prescribers for the right conditions, for the right patients. Otherwise, speaking antibiotics in general, antimicrobials in general, for me, it seems like we are not going anywhere. Let's know that some of them are there. We can leave that. But certain class of antibiotics from now onwards, we want to protect them for the future and move them into the controlled regime like we do for other medicines.
Yes. So you mean to say that it's a good point. So we need more stricter regulations on the availability of certain antibiotics so that we can preserve their potency for the future. Thank you very much. So we are coming to an end of this session on AMS, and I profusely thank all our 3 presenters. They have made wonderful presentations, and they have answered almost all the questions very enthusiastically. So thank you very much, all 3 of you. Join me in appreciating them. And thanks to the technical team, thanks to the FIP team, and big thanks to all of you for an active engagement and your very valid and very nice questions which you have made. And thank you to the audience for all this active engagement. And as I said, I welcome you back at 4:30. So we have not ended with AMR here. We continue. And so please come back at 4:30. We have a plenary session on AMR. And where also in the first part of our session, the Health Minister of Queensland, she will be coming and talking about the role of pharmacists. So I welcome you back at 4:30 here, so you can go and enjoy the coffee break and come back soon again at 4:30. Thank you so much. Thank you, everyone.